My name is Jessie. I am the Director of Social Media here with Global Autoimmune Institute. And joining me this morning is Dr. Benny Kerzner. Dr. Kerzner is a pediatric gastroenterologist. He is the clinical director of the Celiac disease program at Children's National Hospital in Washington, D.C. Dr. Kerzner has been practicing medicine since 1968. Another area of expertise is in nutritional issues, which he has observed and worked with extensively in South Africa. Benny is also a professor of pediatrics at George Washington University. Did I cover everything, Dr. Kerzner?
Absolutely.
All right, fantastic. Well, again, thank you so much for joining us. Today we're talking about telehealth, all the ins and outs of telehealth, its applications, and how it can be used in the future. So I'm excited to dive in. Should we start with question one?
I'm ready.
All right. So the first question I have for you is, could you briefly explain what telehealth is and what a typical telehealth exam might look like?
Right. Well, it varies a lot depending on what you're trying to achieve. So when we say what's typical, I think we have to think about what's typical in what setting. And forgive me, as I was thinking about how we should get going, I'd like to do a little history. So It's amazing that, necessity is the mother of invention, no doubt about it. And I look after these celiac children, and I always start the lecture by reminding people that even out of tragedy, necessity can bring good results. The Second World War made us aware that wheat actually causes celiac disease. It was only when the Allies flew wheat back into Europe that the disease reappeared, and people said, wow, what's
Sandy, we're going to...
COVID is another example, I think, of a tragedy driving necessity. And there's no better example than telehealth, because what we took years to evolve, starting with the space age to now, in about 2 weeks, we put into being, and we've now got a variety of telehealth interactions that we can look at. Okay, so let me try to begin to answer your question. For me, the most typical thing is an average patient visit, and it's wonderful. I have the patient have a booking made. We have a predetermined time. When the time comes, we hook up, we see each other in very human circumstances. For me, a pediatrician, it's wonderful to see the children pretty relaxed, or if they have to be playing with blocks or Lego, gradually becoming comfortable. I think it humanizes me and it humanizes them. So and that is the typical visit, with an exchange of what's the main concern, what we could do about it, and how we develop a plan. So that's a typical visit. But let's look at the other thing that's happening in COVID and just how phenomenal it is. Imagine somebody coming into the emergency room, unable to breathe, and, in extreme distress. And this patient gets rushed into a small room with air being sucked out of it, with people in remarkable equipment crowded together. The person is crashing, and they need to take care of it. They immediately hit a switch. They're connected through a hub to two people sitting very comfortably with extreme knowledge of what to do in these circumstances, and they start directing the care to those around that particular patient. They have the patient intubated. They adjust the gases. They tell them what IVs to put up. They adjust the drugs involved. So we have a situation at the one end, which is highly complicated, facilitated remarkably well by telemedicine, and at the other end of the spectrum, the day-to-day visit. And boy, there's everything in between. Now, I stole the example, I have to tell you, from an article, and I'm going to hold it up here for anyone who's interested. It's in the New Yorker. That's the wrong one. Here it is. If anyone looks at this thing, they can read about that and about telemedicine in great detail. And let's take it from there.
Fantastic. That's a good one. I read it too. So, okay, yeah, let's move on to question 2 then. That was very informative. Thank you so much. The next question that I have for you is on a more personal level for you. How many telehealth patients do you currently work with? And what are some ways that you're seeing telehealth impacting the experience for your patients?
Well, just a word about myself. I do general pediatric gastroenterology, where we see everything from tummy aches to constipation, and I spend a lot of time seeing patients with celiac disease. In the usual visit setting, I might see as many as 12 cases a day. In the multidisciplinary clinic, it would be more like somewhere between 4 and 6 in a half day. The setting for a general clinic visit, I think, is easy to understand. We get together and we can talk about the pros and cons and limits of that in time. The multidisciplinary clinic is a great example of where telemedicine can be highly effective. We have a coordinator. The parents who are in that clinic that day phone in. The doctors and healthcare providers, which include a variety of things. Me, the medical person, a nurse practitioner, a psychologist, an education team, a nutritionist. We can all be scheduled for that patient as needed for that particular person. We're sitting in our individual rooms, and the patient is directed into our room for the requisite amount of time. When they're done, they return to a common room, and then they move to the next person. We have done this in real time in the hospital, and we're now doing it in this mode. And frankly, maybe because we've just been working at it, this mode works wonderfully well. We're able to have the clinicians in their own homes, comfortably sitting wherever they are, the patients coming and going with no time loss between visits. The ease and comfort is remarkable. If it's a private conversation that's needed, the child can be directed to go and play. If they're hungry and they need a snack, and if they've been around for 2 hours and they're bored, they can get a snack. If the parents have something private they want to say, it can be arranged. There are multiple advantages that we're beginning to experience. And frankly, I have to talk about myself. If anyone looks at me over there, they can see a lot of gray hair. I'm 78 years old. I do have a pacemaker. I don't want to go into the hospital right now. In fact, they won't let me. So I'm able to sit at home and function, hopefully effectively, and enjoy, which I absolutely do, my interaction with my patients, and nothing's lost. It's I think, an incredible accomplishment.
Fantastic. And something that you spoke of when we spoke earlier was that a lot of times parents of specifically children with celiac disease have concerns about their children not eating properly, not getting the proper nutrition. And you mentioned that telehealth gives you the opportunity, and other clinicians the opportunity, to sit down and enjoy a meal with the child or just observe the child eating. Can you give us a little bit more detail about that?
Absolutely. Prior to becoming heavily involved in celiac disease, I for a decade was involved in eating disorders of young children, and was lucky enough to be a part of a team. We traveled internationally talking about how this is accomplished. It turns out that I don't want to get too diverted, but 50% of parents believe that at least one of their children's not eating right. And you know what? Most of the time they're wrong. The child is actually eating what they need, but the parent's overly concerned. And then there are a group of children who have serious problems. So what we do is we bring children like this into the hospital. In the past, we put them behind a one-way mirror. We would organize a meal. We would have the parent feed the child. We'd look at the interaction. We had a psychiatrist and myself and a nurse together watching this. And it was expensive and labor intensive and hard to get done. And suddenly we have this modality where we can go into the home. The parent can be sitting there with the child in their setting. We can look around and see, are they turning on the television? Are they distracting the child? What food is it available? What style is being adopted in administering it? Are they responding appropriately to the child? Are they coercive? Are they neglectful? All of the stuff that we can now see in real time in the home, I think, is a major advantage which we're just beginning to take advantage of.
That's fascinating. So very briefly, you have spoken of different professionals coming together in a setting for an appointment. At Children's National Hospital, they refer to that as the multidisciplinary clinic or a multidisciplinary approach to care.
Right.
Can you briefly speak to that and how you feel as though that could be beneficial, especially moving forward with telehealth?
Well, you know, when you're dealing with chronic illness, invariably, there are a lot of aspects to it, and they vary from one individual to another. You can't become labeled with a chronic illness without impacting you, not only in terms of your health, in terms of the tests you require, but your emotional well-being, your adjustment to the illness. If you're a child, what it's going to be like in school. What is it going to be like socializing at parties and so forth? Can you afford to deal with this illness? What barriers are there for you? I mean, I can go on and on. So obviously, for complex conditions, there's no one professional who can pull it all together comprehensively. Now, you need a good quarterback. You need a great primary care physician who gets, who can direct you. But it's probably impossible for the primary care physician in a modern time, with so much knowledge available, so many techniques available, so many testing modalities available, to put it all together. So in a hospital like ours, we have witnessed the growth of multidisciplinary clinics, whether they're to do with inflammatory bowel disease, motility disorders of the liver, of the bowel, liver disorders. You know, every one of these is a complex thing which requires very specialized care. And around each of those conditions, we have a group of specialists. Now, getting them all together in real time, as I mentioned earlier, is a big trick when you come to a hospital. You've got to get everyone sort of leaving and going to the clinic, independent of what else they're doing. It's just not easy to accomplish. I actually think that telemedicine has made available and it has made this a very much easier opportunity. Even if you're in the hospital, you could be sitting in your office. If you're the psychologist, if you're the attending physician, you could go into a room nearby. And I can go on. If you're a nurse, if you're an administrator, everyone can be where they are. We can get together and we can conduct this interaction. And over and above that, we can all be at home and do the same thing. And we can do it at odd times. It doesn't have to necessarily be between, 1 and 4. Maybe it works for 6 o'clock. Maybe it's a mother who can't be there at any other time in any convenient way. And if she's traveling back and forth with her child for every individual meeting and coming, in our case, from Southern Maryland to DC with a 2.5-hour ride in each direction, imagine what an accomplishment it is that she can stay home and in one setting in half a day, get all of that interaction. And better still, the team can prepare for that visit before she comes. We sit around for half an hour, 2 days before and say, oh, we're going to be seeing so-and-so. What were the issues last time? What will they need to have in anticipation of that visit? Can we still get it done? And at the end of the visit, we can sit around again and say, well, what do you think as a psychologist? Should we be doing X or Y? Is this the right time to intervene? So, the more you think of it, the more you realize what the opportunities are. Now, we can come to them. This is not without limitations. But we're just at the beginning. I would love to come back in 50 years' time and check this out because I think it's going to be amazing.
Excellent. Thank you for that. So you did mention limitations, and that's where I wanted to take the conversation next. So what are some possible limitations of telehealth?
Well, we need to look at them at various levels. There are limitations for the patient, for the doctor, for the institutions, and all of them, and for the country, actually, all of them are important. So the first, just the licensing, for instance, up until now, if I have a license in DC, for DC and Maryland, I can't see someone in West Virginia unless they come to me. But if they're in West Virginia and we're doing telehealth up to now, they were out of my domain. Well, happily, we've passed laws now that, at least for this period, allows us to interact beyond those boundaries. And suddenly you can get there. But those laws are going to go back into place unless we have legislation that takes advantage of what we've learned and, overcomes those barriers. And there are significant reasons why there should be barriers. What's applicable in one area might not be applicable in another. Standards in one area may not be the same as another. So maybe we need a more national guide. To get that, we're going to have to legislate. So there's a lot of work to be done as we go forward. Within the institution itself, there are limitations. We have a healthcare system that is designed to be fee-for-service. There's tremendous advantages to the institution having people come in, use their services, and they've got a business model that is constructed around that interaction. When we take and suck all of that income out of the system, we're going to see the collapse of small hospitals. We're likely to see the collapse of other things we just can't afford to lose. So we're going to see resistance to these changes, driven by, legitimate concerns about survival. Now, if we get down to the more practical limitations for the interaction, not everyone has broadband. Not everyone has a cell phone. Not everyone can use one. There is enormous need to improve our infrastructure, not, I believe, for other reasons as well, but certainly within the context of medicine. I think that's going to bring to light the absolute need. Education has done the same thing, obviously. How are we educating our kids now when they can't get to a phone or they can't get to a screen? So maybe the two will get together and we'll see stuff happening. So we're going to have to persuade our governing bodies to pitch in and do something and help us out. And that's a limitation. Who does that? And then there's connectivity. Even when you've got all that stuff in front of you, it's been wonderful in this way. We've always counted on about 20% of patients not turning up for visits. I mean, that's a standard across the country. People who have to travel distances, have all sorts of things. So we sit around for 1/5 of the time, which is enormously expensive. But right now, if the no-show rate has dropped to almost 1 or 2% for me. It's massively improved, because if the time comes and they haven't connected, I pick up the phone and immediately phone them up and I say, where are you? And they're usually saying, I'm desperately trying to push the button here, but my adolescent child won't show me how. And, but we walk them through it. But sometimes it's not possible to walk them through it. Sometimes they don't get the link. Sometimes they get the link and they don't understand what it is. So that is actually maybe the biggest barrier that I've encountered. And just, getting past that practicality. The other end of the subject, the other piece is actual documentation. How do you document an interaction that's happening live so that you don't forget stuff and you're getting it down on paper? I'm a two-finger typist. I cannot possibly keep up with a conversation that way. So, I'm trying to dictate at the same time as I'm trying to interact. So there's some practical issues that occur in the course of this that we have to iron out. Once this is done, there are limitations. How do we get the instructions to the patient? How do we arrange for follow-up? How do we arrange for additional communication that may be needed? We are finding methods that are working more effectively. The portal systems that you're probably all aware of, are very helpful, for instance. So those are some of the things I can think of offhand.
Fantastic. Thank you for that. Let's move on to the next question. So, and I think that there's a little bit of the previous question in this, but right now there's a huge conversation within the world, within the medical community about certain things that are in place in society that limit people from having equal access to healthcare. So in terms of talking about equitable access to healthcare, and especially to telehealth, is there something that you feel that physicians or even hospitals can do to advocate for bringing those services into patients' homes, specifically and especially with the technology, with the broadband, and any other things that are necessary for patients to receive telehealth care?
The short answer is I absolutely believe it, and I feel very strongly about it. I'm sure many, many, many people do. I think the disparity in opportunity and wealth, unfortunately, has very practical consequences. And you can look at it in two ways from my perspective. One is how it disadvantages the very people who need it most. And on the other side, it's very expensive for society. You can make the case, I think, quite strongly that people who don't have access to healthcare find ways to use healthcare that are extraordinarily expensive. So for them to do so means they've got to go to the emergency room. I mean, it's expensive for them too. They've got to transport themselves there. They've got to get in there. It is really miserable. And for the country, you're then paying for their care indirectly via a very expensive modality. So I think the politicians have an opportunity, and the medical profession and the medical societies have an opportunity to look at this and we all understand this. Right now, we're so polarized, we can hardly say good morning to each other. But if we can get over that and say there is a real problem, if we can sit down together and say let's solve it, rather than polarize over it and use it as a political football, our healthcare system needs a lot of care. There's no doubt about it. And I better get off this soapbox. I don't know if I've covered the answer or not.
There was one you mentioned when we spoke earlier, and that was specifically about translation services and the ability to bring translation services into.
Thank you for bringing it up. Now, that's important. That's one of the aspects of this is you can, I do not speak Spanish. So when I get on the line with someone who's Spanish speaking, that's an issue. Now, our hospital has been very effective in arranging translating services within the institution and beyond. But telemedicine actually is wonderful that way. To have the translator as part of the meeting, and they can come in as readily as we are and become part of the team, personalizes this wonderfully well. And it is a big deal. It is one of the real limitations, and you need a lot of different services. Now, if you look at the amount, we're in DC, we have a very multicultural number of patients coming with all sorts of languages because the embassies and whatnot. So we have a list. If we want somebody who speaks a Slavic language, we can get it. We can get a Spanish person. We can get German. We can get whatever we like. And we can bring all of those into the room, and we don't have to employ the whole lot. This allows us to be selective.
Great. And you also had spoken about health insurance as well, and how to deal with issues surrounding getting around health insurance issues, and allowing patients to still be brought in.
Right. Yes. The insurance carriers have also been a barrier because obviously, they have different, what's the word I'm looking for? There are different levels of acceptance and what they'll pay for and what they won't pay for.
Mm-hmm.
And certainly we have to advocate for the acceptance of telehealth as a legitimate interaction requiring appropriate compensation for both the doctor and the institution. And, it's again a political issue that's got to be resolved. And we're in a time of change where that's got to be worked out. The fee-for-service model required that you went in and you got a service. The fee-for-service model here is not nearly so clear-cut. For instance, that patient I described who goes into the hospital and is desperate, and they have a hub that brings in somebody who's sitting in Newfoundland, who's wherever, actually monitoring the care. How does that person get covered? How does the insurance work out? What's appropriate there? There's a very complicated piece of politics which I don't understand, but needs to be resolved.
Mm-hmm. Great, thank you. And another thing that we spoke about earlier was the idea of, and you kind of briefly mentioned it, but the idea of having a hub where a patient can avoid the long travel times,
Right.
But still be able to experience some inpatient care as well. Can you speak to the effectiveness of that in carrying out a telehealth plan for a patient?
What I spoke about the extreme example, someone in desperation going into an emergency situation, but we have set up more manageable hubs and more practical ones. So say now we have patients in Southern Maryland. If we can identify a practice there that could act as a nidus for our patients and identify, say, a nurse practitioner, and the nurse practitioner will see the patient when they come in, do the blood pressure, get the weights, sit them down by a computer, and for the visit, we can be sitting in our multidisciplinary clinic and interact with that patient, not only having the benefit of their presence, but they don't have to travel. If they don't have the equipment at home, they can get it right there. In addition, all the vitals are done. In addition, we can get back to the nurse practitioner with the instructions, and the orders can be written right there, and or the blood can be drawn right there to facilitate the further management. I think that model is a very practical arrangement there. Our hospital is well. We're really in a good position to foster that because we have connection with so many primary care practices, which are often run by people who we've trained. And so there is a very close interaction, and it could work very well. And we have examples now where we've done that, and they need to be further developed. We're in DC, we have an arrangement with a practice in Frederick, but they're seeing people who are coming down from Hagerstown. Now, I don't know if the viewers know the map, but there's a lot of miles between these places. So we could set up one in Hagerstown itself and do the same thing.
Fantastic. Could you triangulate that a little bit for us in terms of what the distance would be between those places, and then what the distance would be to, or the travel time rather, what that would be to the kind of middle point, just so we can get an idea of what that might look like?
Well, traveling to Southern Maryland, I've done that, and I was horrified to find how long it took me, because we see lots of patients who come up from there, and I don't remember the miles exactly, but it was a 2-hour drive. I regularly practice in Frederick. I go up to a clinic there, and that's an hour's drive, okay, depending on traffic. If I go beyond that to Hagerstown, that's another hour. So, you know, people driving all the way down and back, that's a day out.
So these hubs could really be a great way to address some of the challenges that people might face for receiving quality care in terms of time taken off of work, in terms of expense for travel. This could really be a transformative thing for patient experience.
Oh, so much so. Imagine, you know, people who bring their children have to go and explain to the boss, I have to go, my child's sick again. I know how that feels when confronted by staff who can't come to work repeatedly because of this. And for that person to be able to take off an hour, even at work, and get that done, or go in and get it done and not come up, I think it's enormously helpful for everyone. You know, it's calculated by some, at least according to that article in the New Yorker, that 50 to 70% of visits to a doctor could potentially be replaced by telemedicine visits. That is astounding if it's true. And even if it's half true, it's astounding. And I have no doubt that whatever it is, the number is very, very high. I don't want to pretend that it's perfect. You know, please, there are times where you really need to go in and be examined. And there is a great risk that things will be missed that would otherwise not be missed. I mean, the downside, you know, just for adult medicine, for instance, if somebody has a gastric cancer and they're having tummy ache and it's written off as, you know, mild gastritis or irritable bowel syndrome or something, because they haven't really, the doctor hasn't had an opportunity to put a hand on that abdomen and get a real sense of what's going on. So a balance has to be struck, and it's not going to be perfect, but there's plenty of room for improvement. Sure.
And I think that that's an important thing to bring up. A lot of times there just isn't any substitution for a physical exam. I think that's something that doctors are contending with a lot right now and trying to figure out how to best apply telehealth. And with that said, I know the New Yorker article mentioned that there is some technology that allows for patients to collect vitals, I believe from home. Is that correct? And somehow have them logged for the physicians?
Absolutely. You know, it's amazing what we now have available. I, for instance, at home have a blood pressure cuff. It's absolutely simple to take your own blood pressure. Beyond that, I have a little thing that you put your fingers on and it does an EKG and tells you your heart rhythm. And I can take that recording and send it to my physician. And, you know, more and more technology is overcoming some of the barriers. But when all said and done at this time, really, I think it's important to emphasize that there are times when you cannot replace a hands-on examination. And you know, people need to be aware of that. And if things don't get better, maybe it's always important to set limits and say, you know, within this much time, if it's not working, I'm going to take the next step.
Absolutely. Which leads me to another question for you. How do you determine which patients are a good candidate for telehealth versus in-person care, rather?
You know, I do it reasonably frequently now. I'll have a phone call with a patient if I see that the situation is stressful, you know, and try and work out what's going on. It's on a one-by-one basis for me because the patients are booked for me via the hospital and I just see them on Zoom. But every now and then a physician will phone me and say, I'm really worried about X. What should I do? I'll get on the phone with them and explore just how urgent does it seem. You know, there are red flags that we're all taught to recognize. So just to give you an example, if somebody's having tummy aches, it's one thing. If they're having tummy aches, but they're also seeing blood in their poop, it's a whole different story. So, you know, you've got to put those pieces of information together. I think another thing is to ask to what extent this is interfering with your lifestyle. You know, if you can't function and we need to get more testing done, it needs to be more in depth. Clearly, that's a good reason to bypass this. But unfortunately, it's true to say that we have a great many patients who are labeled the worried well. Their worries are not illegitimate, but they're fundamentally healthy. And I think that's where the biggest opportunity lies.
Fantastic. Thank you. Something that was interesting that came up in our previous conversation, you mentioned to me that in a traditional clinical setting, your no-show rate can be quite high. Right. And you've noticed that there's a difference in telehealth. So can you elaborate on that a little bit for our audience?
Well, it works on both sides of the equation. I think part of it is that the ease with which the visit can take place helps. So if your child is running a fever or your other child is not well, or somebody has to stay home and needs to be looked after, you know, that accounts for a fair amount of this. A lot of it is the result of miscommunication. People have the wrong date. You know, all sorts of mistakes happen. But here, it's so much easier to connect, and we can remind them in real time. So as I said earlier, I can get on the phone and say, where are you? And, you know, I would say that doesn't happen that infrequently. And 90% of the time they say, oh, I'm so glad you called. We can do this.
Great. Is there a specific window of time for patients to be able to come to a telehealth appointment? For example, I know a lot of times with doctor's appointments, after 15 minutes or so, they say, you know, we have to move on to the next patient. Is there a kind of a bigger window that's afforded if people are running behind or experiencing technical difficulties to get into their telehealth appointment?
You know, I think if the time's corroded, the right thing for us to say is your time's being corroded, but I have 15 minutes. Let's see what we can get done and we can, you know, take it from there. I can say for our department as a rule, although we have a 15-minute cutoff, we have a clear understanding amongst us that our patients come from a long distance, that many times their problems are highly legitimate. A child with, say, who's got cerebral palsy, who has to be put into a wheelchair, who has to be put into a car, who's waiting for transportation. So sticking to a 15-minute deadline, you know, might work in the northern suburbs. For Children's Hospital, we try to be a whole lot more flexible. And even if we spend 5 or 10 minutes, you know, we try very hard not to have an absolute cutoff.
Excellent. Have you experienced, or do you ever experience patients' families who they give the telehealth thing a try and they just say, it's not for me, it's too much technology, I'm having too much difficulty? Do you ever experience that?
I've heard of patients who've said that, but I honestly have not encountered it personally. I can say that the great majority of people, I'm quite confident of this, feel that they've had a more comfortable interaction for the visits that I have.
All right. So the next question that I have is, do you feel that telehealth will play an important role in the future of healthcare?
Absolutely.
Okay,
I have no doubt at all. No.
fantastic. I know that in our conversation beforehand, you had mentioned that you had been trying for years to implement telehealth as an option
Right.
for healthcare, and then as soon as COVID hit, it took, did you say 2 weeks for it to be implemented across the board?
Yeah, it's amusing. You know, there were all the technicalities about licensing, about permission, about, you know, lots of concerns that we were working our way through. Now, let me add that there were parts of Children's Hospital that already had telehealth working pretty well.
Mm-hmm.
But we were trying to get our multidisciplinary clinic and other things going, and it was taking forever. And it's true, within 2 weeks of COVID, we had somehow found a way to do it. And it was a matter of so many barriers that just suddenly were withdrawn. I don't know what more to say.
Okay, cool. Well, let me ask you this. Speaking of, what was your experience prior to COVID-19 with telehealth, and what made you so passionate about implementing that into everybody's everyday healthcare experience?
Well, I became very convinced when we were doing feeding disorders that this was the way to go. That instead of bringing these patients in and putting them behind one-way mirrors, we had a setup where we were actually seeing them in real time in their real homes, behaving as they would more normally do. But with that in mind, we tried, and you know, it isn't always successful. I'll give you a quick example. The first time we did this, we had the doctor, the dietitian, the oromotor therapist. We were all lined up in our various offices, and at the other end, we had the mother with the child. And the child had one look at us, burst out screaming, ran out of the room, and we never found them again.
Oh no.
So it doesn't always work exactly as you envisage, but you know, that set us back quite a while.
Sure. I know that you did mention in our previous conversation that telehealth kind of plays to the nature of a lot of, especially young kids, when they're trying to figure out who they are and how they interact, what their interactions are going to be like with people. Children have a tendency towards shyness, towards reservation when they're very young, and they seem to really flourish in these screen
They do. I think they're very well, the very young kids, it's variable. Some of them feel shy, you know, no matter what. I think the somewhat older kids are so used to using social media and communicating this way that it's very natural for them. There was a letter written in that New Yorker that I referred to in the front that I found very interesting, by a therapist who pointed out that she enjoys telehealth because it humanizes both her and the patient. That within the traditional setting, it feels very cold and clinical. Yet in this setting, you're just within your environment, they within theirs. And she felt that humanizing each other actually facilitated the communication and sort of took her out of a rigid kind of place. We're reminded of the fact that in your office, you tend to be sitting with your notes. And at the beginning, when the patient comes in, you're sort of going over everything. And the patient sitting there looking at your degrees and your family photographs, waiting for something to happen. And, here, immediately, it's eye-to-eye contact. You really have to engage. It's just very personal. Did I answer your question?
You did, yeah, that was fantastic. Thank you. I did have before we wrap up, I do have a quick listener question, and
Sure.
that was, do you feel that with telehealth, there is a way to continue with providing quality healthcare while also observing and respecting the cultural practices of all patients?
I think their answer is yes. I'm not sure what particular cultural practices we're alluding to. There are a lot of cultural things that come into these human interactions. I mean, physicians are afforded remarkable access to people in terms of their physical bodies, their minds, their homes. I think we will always, a good physician, I would hope, would always be sensitive at all of those levels. And, I think we're there to advise, not to judge, and not to order. And I think if we can adopt that, hopefully it works. I feel there's more behind that question that I don't understand. But in the main, I would hope we can deal with those things. Sometimes I think it really helps to have someone of your background in front of you. It's easier to communicate that way. There's no doubt. And I think it takes a certain sensitivity to go beyond your background. And probably there's some places where we don't go. I'll end it by saying this. I was taught early on, I was in private practice for a short while as a young doctor, and my boss went away. And while he was away, one of the patients came in and wasn't happy with me and left the practice. And when he came back, I was highly embarrassed, and I explained to him, I feel so bad. I did my best. On her way out, she said, I don't want to see that doctor when I come back. He's still reading it in books. And it's because I was looking up stuff while she was there. And he burst out laughing, and he said to me something I'll never forget. He said, if you're really good, 80 to 90% of people will like you and will want to work with you. But if you're aiming for 100%, you're going to be really disappointed. And I think, there are cultural differences we can't overcome. I think we need to recognize them and accept them. And hopefully, if you're a good physician, you redirect that person to someone who's more capable of dealing with that. But you can't hope to understand all of the intricacies, that go into a personality.
Sure. That was a fantastic answer. Thank you for that. So the final question that I have for you, and I think we've kind of been threading this through our whole conversation, but can you describe how you visualize the future of healthcare with telehealth?
I don't know where to begin. All I can say is I think it's here to stay, and it's going to evolve. I think our technology is getting better and better all the time. It always outpaces our imaginations. They'll find ways to overcome the barriers. But so I do believe that a large number of visits will become telehealth visits, and that it will be a major benefit. And as I implied earlier, I absolutely believe that in the end, there are going to always be those patients who need to be in a face-to-face encounter with their healthcare providers, and we'll just rebalance. But I think the nice thing about this is maybe the COVID thing has brought into focus both the limitations and the opportunities. And hopefully, we can work together to take advantage of understanding both.
Sure. So for physicians who want to implement telehealth long-term in their clinics after things kind of return to relative normalcy after COVID, is there any advice or are there any thoughts that you would give to them?
I think if they're within groups such as Children's Hospital, that's going to be done for them. So I think that's easy. I think practices are getting together and joining with commercial companies that have already seen the benefits of telehealth and are offering ways to make that happen and incorporate practices into it. So I suspect we'll see networks, evolving. I'm sure they are already, that allow these practices to bring it into, because there are a whole lot of issues like how do you book the patients, how do you schedule, how do you, there's a whole new technology behind it, which these commercial providers are, I think, stepping into. I don't know their names offhand, but I've seen a number of them already.
Great. I think that concludes all the questions that I had for you this morning. Do you have anything to add in terms of just the overall application of telehealth, or how telehealth can be applied to help close some of these gaps that are now being exposed in terms of people's access to care?
I'm going to tell you, I think I've covered all I know and more.
I love that.
I'm not going to say that, but I want to say one thing. Thank you for giving me the opportunity, and I hope it's helped at least some people. Certainly, I enjoy talking this way. I love speaking, unfortunately, and it's been a pleasure. Thank you.
Yeah, absolutely. And you're a professional at Zoom now because you use Zoom so much for your career. So you probably know more than I do.
Thanks a lot. Take care. Thank you so much.
Yeah, I just want to thank you so much again for joining us. This was very informative, and we really appreciate your time.
It's a pleasure, Jessica. Thank you.